Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
Good afternoon. My name is Maxim Itkin. I'm an interventional radiologist at the University of Pennsylvania and Nemours Children's Hospital. I've been in the University of Pennsylvania for the last 22 years. And since I came here, I started express some interest in lymphatic imaging and interventions, primarily because one of my mentors, Dr. Konstantin Kopp, who is the father of the interventional radiology, just before he retired, he started to think and conceptualize the idea of the accessing the lymphatic system and performing certain intervention. And of course, when you have some interventional options, the first was what's called thoracic duct embolization, we started to explore diagnostic options as well. So here I talk about new development in the central lymphatic imaging and interventions that pretty much summarize probably 50–60% of what I've been done for the last 20 years. More new stuff. I probably wouldn't talk about some old development because first I already gave talk a few years ago, so I'll try to focus on the new stuff. At the end of it will be approximately 35–50 minutes, and at the end I will answer the question. This is my disclosures. So what are lymphatic flow disorders? Generally, you can divide them very roughly. Of course, it's very approximate into the lymphedema or occlusion of the lymphatic system or lymphatic leaks. So in my focus, of course, on this primary lymphatic leaks. The lymphatic leaks are actually not uniform, they're different. They are related to the type of lymph is leaking, or because there are actually multiple lymphatic fluids in the body. Each organ generates a slightly different lymphatic fluid, such as soft tissue fluid, chyle, that is mesenteric or intestinal lymph fluid, and liver fluid. This is the three lymphatic spaces with we are working. There's, of course, lung, kidney, spleen, that completely outside of our understanding at this moment, or diagnostic or treatment. So sometimes you have a combination of the lymphedema and leakages, for example, scrotal lymphedema, and lymphorrhea. So let's move to the lymphatic leakages. So there are, it's a kind of extension of a previous slide, but you can see that chyle, that the intestinal lymph can leak in multiple places. Pleural cavity will be chylothorax, bronchial tree, plastic bronchitis. Abdomen will be chylosisitis, kidneys, chyluria. Soft tissue, a little bit less common. It's if it's leaking abdominal, most of the time it will be after surgery. We'll call about, say, groin abdominal lymphocele, or something that we see quite often, scrotal lymphorrhea in patients with often associated with lymphedema. And liver, we'll have a liver lymphorrhea, post-surgical most often, and a protein losing enteropathy. So what is contemporary lymphatic imaging? The major problem with lymphatic system over years was imaging. We didn't know how to deliver dye in the lymphatic vessels. So over the last probably 10 years by now, we developed, and other groups, of course, developed techniques of interstitial lymphangiography. And what is that? It's very simple. You take a needle, position at the lymph node or lymphatic mass, inject dye, and this dye seeps through lymphatic vessels into the lymph node or lymphatic mass into lymphatic vessels. And we have a few default types. It will be intranodal lymphangiography, MR lymphangiography, liver lymphangiography, something very new, CT lymphangiography, and mesenteric lymphangiography. So this is a typical slide I show all the time. How do you do the nodal lymphangiography? When I say nodal, most of the time we mean by that groin lymph node. Again, simple, put a needle into lymph node under ultrasound guidance and inject dye. That's how, on the left, that's how it looks on the patient. On the right, that's how we do see the lymphatic ducts on the x-rays. In the bottom, there are few lymph nodes and then multiple lymphatic ducts in this groin. But besides groins, we can actually inject contrast in different locations. Liver will be liver lymphangiography, mesenteric or intestinal, mesenteric lymph nodes, we can do intestinal lymphangiography. This is an example of MRI. That's where we inject in the lymph nodes new contrast. That's called gadolinium MR contrast. And the beauty of this technique is that we actually can get these dynamic images of the lymphatic system. If we substitute gadolinium to the regular CT contrast, we can see these beautiful images of the CT lymphangiography. And why this technique is important now? Because it's readily available. MR lymphangiography is very, very valuable for us to diagnose lymphatic disorders. Again, we're talking about central lymphatic disorders and not peripheral lymphatic disorders at this moment. This MR lymphangiography is relatively difficult to set up. Also, MRI is not that much available outside in a lot of countries, but CT is quite common. So I can tell you, since we published this paper a year ago, there's another 3-4 paper came out, and I get at least every 2 weeks email from somebody saying, I'm so excited I successfully implement this technique in my hospital. It was so easy, and we get beautiful, beautiful images. Liver lymphangiography, we do the same way. We put a needle very, very close to the portal vein. Portal vein is like main vein in the liver, and all lymphatics live there, and then they inject dye. And suddenly it provides us another huge amount of information. And for example, in this patient, you can see on the bottom of the screen, there's a multiple errors. That's a leakage of the contrast or lymph in the duodenum of this patient with PLE. We of course can do another CT lymphangiography. This type is it's intraoperative CT lymphangiography, and they can see leak even better. So mesenteric lymphangiography, what is that? It's lymphangiography of intestinal lymphatics, and it's the most difficult and challenging one because it's so difficult to find mesenteric lymph nodes percutaneously, just through the skin, like you can see here. But it's extraordinarily easy to do if we do it during open surgery. Why this technique important? Because it's holy grail of chylothorax and protein elution enteropathy. So by developing this technique, we can potentially provide a final solution for a lot of people with these two diseases. And you can see that how it looks like an X-ray. Small lymph node here, and small beautiful lymphatic ducts. So this is the diagnosis. What our therapeutic approaches? First, we can glue. What leaks. It could be either thoracic duct embolization or gluing for chylothorax plastic bronchitis, or when over the last few years, we developed this interstitial lymphatic embolization. What is that? It's like we inject dye, but instead of dye, we inject glue. And we use this technique extensively, more than probably thoracic duct embolization right now, for chylothoracitis, protein elution enteropathy again, liver lymphatic chylothoracitis. But the most exciting one, this is the last one, lymphovenous anastomosis, thoracic duct venous junction angioplasty. Two different procedures, but idea the same. to try to decompress or connect the main thoracic duct to the vein. It could be again done by surgery. I do have 2 cases today with surgeon. I'm actually giving talk between 2 cases. We started to do a lot of these surgeries. I worked with very, very talented surgeon here, Steve College. And I will talk about different indication for this surgery, but also we started to put a balloon, and it does work. It does work perfectly, but it does work quite well, especially if you have total occlusion. The beauty of this balloon technique, of course, it's minimally invasive, could be done within 15-20 minutes. So what is the pathophysiology of lymphatic flow disorders, primarily leaks, but probably lymphedema as well? It's combination of anatomical variant, so people been born with fine lymphatics, increased lymphatic flow production, definitely in kids with Noonan Costello Down syndrome. There's an enormous amount of lymphatic flow generated. We don't understand why. Patient with complex lymphatic malformation like GLA, KLA, and sometimes people just have a strong and fast lymphatic flow. And of course, heart failure and liver disease. But also we quite often see upstream anatomical obstruction, either by other structure or just obstruction of the thoracic duct, and I will show a few. This is obstruction of the duct by abnormal artery that crosses it and compresses it. It's here and here, the places. So let's talk about the most common condition we treat. Almost probably causes ascites as right now even more common. It's a condition that associated with abnormal lymphatic flow from the thoracic duct, or this green structure here, into lung parenchyma. And on the left, you can see an incomplete list of different conditions. So, and what happened is that there's a flow, enormous flow going through thoracic duct, and suddenly somebody has a small branches that go into bronchial tree. In that case, it will be plastic bronchitis or chyloptysis. The difference between them is plastic bronchitis is just a whipping of the proteinaceous fluid from the wall, mucosal wall, whereas chyloptysis is just freckling. So chyloptysis is deadly, whereas plastic bronchitis is less morbid than chyloptysis. If it's going toward interstitial lung parenchyma, will be interstitial lung disease. And we have a lot of patients that came to us recently with clinical presentation of interstitial lung disease that end up abnormal lymphatic flow. And of course, chylothorax, already talked about that. So we've been working on chylothorax for many years now. And I think we'll get to the point where we know how to treat it very, very well. And I showed you the data we just published recently in Annals of American Thoracic Society 6 months ago. And this is algorithm of the treatment what we implemented a few years ago. And the idea here is that the patient present with chylothorax, non-traumatic. The most important thing, exclude ascites, because ascites can present as chylothorax. And if we did figure out an ascites, we can treat it as ascites, and I'll talk about that a few minutes later. But if it's not ascites and really what we call true chylothorax, there's a two situation where there's flow from the thoracic duct and lung parenchyma, as I just said, or there's abnormal connection between the retroperitoneum and pulmonary circulation. And embolization of both of them can cure the patient. And this is an example of the leakage or flow of a lymph from a thoracic duct toward lung parenchyma. And this is just schematic representation of the same idea. But here you can see the patient has leaked from both thoracic duct, but also retroperitoneal into mediastinum. So you have to close both thoracic duct in this case and this retroperitoneal thing. So how do we do that? We do thoracic duct embolization. This is 3 stages or 3 parts of the procedure: intranodal lymphangiography, thoracic duct access, and thoracic duct embolization. So this is intranodal lymphangiography, as we already talked about that. We perform it with contrast, what's called lapidol. It's oily dye that's not diluted by lymph, so we can see it quite well. And then we take a needle and stick some type of target in the abdomen and try to push a wire in this lymphatic system. That's how it looks on the patient. And then I glue, coil it with coils. This is how we deploy coil. It's really coil. Of course, bit sophisticated and expensive. And this is how we deploy the coil, and then we inject glue behind the coil. So, and the glue is already opaque, so you can actually see it quite well. And this patient, we embolized thoracic duct, but it was not good enough because on the left of the patient, on your right, there's a communication between these lymphatics and pleural cavities, so we had to glue them as well. And this is our outcome. The first two groups, 1 and 2, one what's called true chylothorax, we have a very good response rate, 97 in thoracic duct and 90% secure rate of this mesenteric, retroperitoneal leak. In group 3, 11 patients, we'll talk about that group later. And here's later. So this is our new approach for chylosarcoitis, non-traumatic chylosarcoitis, of course. So what do we do? First, we do again MRI. On MRI, we can actually see leak. If we see leak, that's great. That's super easy. We go and glue it. Very, very good. But more often, we see nothing on MRI, lymphatic geography. No leak, and maybe dilated thoracic duct. So in that case, we'll try to open thoracic duct more, allow the fluid to go faster. Or if there is absolutely absence of the thoracic duct, in that case, we do intraoperative embolization. And on the left, you can see the leak. You see this kidney here? This is the leak. So that's straightforward. That's relatively easy. And that's how we treat it. You can see that we put a needle on the right, of course, needle into lymph node, and we inject glue. And you can see the glue eventually goes through all the lymphatics and leaks into this leak. So this is the most exciting part, or the most exciting situation recent. This is a patient chylosarcoitis, and you can see we inject thoracic duct, and there's at the tip of the thoracic duct is a certain debris. Number one, number two, the patient has actually a port on the same side. So what we realize here that port created this obstruction clot at the tip of the thoracic duct. And what we do balloon. We go and put a balloon across this stenosis inflated, push the clot out. And this on the right side, you can see that this is post angioplasty imaging and chylosarcoitis in this patient. Sorry. The next picture is a bit graphic. So if somebody next to slide, so if somebody wants to turn off video, okay. So the next technique for us, if we completely failed, will be open the abdomen and try to glue directly. And what we do differently here is that we'll take a little bit special color, add to the cream, and feed the patient just before that. So actually, we're doing this today again, case number 3, with patient with chylosarcoitis. And this is the beauty of this color. It's color all the lymphatics beautiful blue color, and we actually find the lymphatic leak much easier, right? So the only downside of that is every time we do that, we usually get FDA approval for compassionate use. It's a little bit paperwork, but right now they know us, so it's relatively easier. And so that's how we see. But sometimes we actually can see leak exactly. You can see on the right small leak, and on the left and on the right this milk coming. We actually take a syringe and inject directly into the leak. And we're not as good with chylosarcoitis as with chylothorax. Pretty much, if we see the leak, our success is 90%, close to 90%. If we don't see the leak, it's 71%. So of course, the last one is not good. But we also started to realize that with some chylothoraces, chylosarcoitis, that we treat are patients with obstructive mesenteric lymphatics, and there's nothing for us to glue or do at this moment. We're working on figuring out how to connect a lymphatic ducts to the vein in the abdomen, but we've done it only once, quite successfully, but it's still not a standard of practice. So we hope that we improve these numbers. So if we already touched about this new exciting thing of angioplasty or thoracic duct venous or lymphovenous junction surgery. So we do it probably 5-6 years. We started with small babies, published two papers, but right now we started to do it more and more on adults as well. And at this moment, we have a few indications for that. Number one, callus ascites. Callus and non-callus. We actually have both. We've treated a few patients with totally unexplained ascites, and when we did this angioplasty on the stamosis, ascites gone, protein-losing enteropathy for sure. And the one is very, very, very interesting and exciting as well, chronic abdominal pain. And I'll talk about that in a few seconds. And we're absolutely sure, there's one missing here, sorry. We started to already treated few patients with lower extremity edema. But the one that developed either after surgery, and when I'm saying after surgery, I mean after any surgery. We have patients post spinal surgery, prostate surgery, hip surgery. So patients wake up and have swollen legs or swollen scrotum. And we found that they have obstruction somehow developed during the surgery. Some type of clot sits inside the thoracic duct venous junction. The moment they clean it up, in most of them see significant improvement of the symptoms. And for future, of course, we think about heart failure, and ascites, and liver cirrhosis, and multiple other conditions. So that's patient presented with severe abdominal pain, and you can see the thoracic duct. We inject thoracic duct on the left. There's definitely dilation at the tip. So we advanced our wire, and you can see, that's enormous amount of debris will flush out of thoracic duct. Why is it debris there, and why it was created? We have no idea. We'll probably know at some point. But the culprit of that was actually stenosis of the, you can see it here, stenosis of this, stenosis of the thoracic duct venous junction. So what we do, we actually advance the wire. And by the way, you can see this is something bouncing here. This is a small debris that's still attached with a string to the thoracic duct. So we advance the wire. We capture a wire with a special snare from the leg. Sorry, I'll show you in a second. This is capture it and pull the wire all the way through the leg. And then from the leg side, and this is how we capture the wire. Here, the graphic is from the arm, but that's what we did at the beginning. Right now, we did for the leg. And then we put the balloon, advance the balloon on the right, and open it up. And here's injection after we angioplasty. It doesn't look significantly improved, but it's actually all symptoms in this patient disappeared. So this is the data we presented, but we actually have a bit more patients, I think 9, and more coming. And what's striking is that they are all women, primarily young women, and clinical presentation from severe, horrible abdominal pain to the chronic daily abdominal pain. And obviously, we found abnormal communication between thoracic duct and vein, and the patient are doing quite well. With some of them complete resolution, and some of them significant improvement. So we're still working on that, and we will continue to work. I think it's very exciting that we can provide care to this sometimes miserable people that couldn't eat anything for years. Another condition we started to treat is ascites, not necessarily callus ascites. And what in this patient we found that thoracic duct venous junction was obstructed by dialysis catheter. So we wanted to remove the catheter and angioplasty, all his ascites gone. So this is post angioplasty. Again, because it's low flow system, sometimes the results not very impressive radiographically, but they actually clinically working very good. So next lymphatic system that we will be talking about is liver lymphatic system. It's very important one because liver generate enormous amount of lymphatic fluid. And the reason for that is because of physiologically, where the liver lymph is generated, it's very porous. So even slight increase of the pressure in liver can increase significantly thoracic lymphatic flow. And what's another important is this liver lymph is very rich with albumin. So that's how it looks like. There's a communication between the liver and periportal lymphatic, so it's drained that way, but also the communication directly with the chest. And we strongly feel that it's under this communication between the liver and chest, it's underdiagnosed area because we found quite a few patients right now, but because of this communication have significantly mortality, pleural effusion, plastic bronchitis, and so on and so on. That's how liver lymphatics not normal look. They are quite dilated, communicate with thoracic duct. So this is a few conditions that we treated. Liver lymphorrhea post-surgery, some type of surgery done next to the surface of the liver started to leak, protein loss in enteropathy, chylous ascites, chylothorax, plastic bronchitis, and heart failure ascites. How do we do liver lymphangiography? We actually put the needle very close to the biggest vein in the liver. It's called portal vein, and slowly start to inject contrast. Here's the child post Kasai procedure. Kasai procedure is procedure where children that born without bile ducts have bile ducts connected to the duodenum, and you can see that there's we do liver lymphangiography, and the lymph is leaking directly from the liver lymphatics. Again, this kid is put in 1.5 liter a day, and then we glue it, and exactly the same way from a needle, direct injection, and kid is cured. So the next important disease is protein-losing enteropathy, and the first very straightforward and easy for us this condition, it's protein-losing enteropathy in congenital cardiac disease. We used to struggle with that, of course, trying to figure out what's wrong. Right now, we know exactly what's going on, and we think we developed quite a good treatment. And protein-losing enteropathy, of course, it's a severe loss of serum proteins into the intestine. So many years ago, but now 5 or 6 years ago, we said, let's think about heart. We know that liver have a high concentration of proteins, specifically albumin. The lymphatic flow in the liver increases significantly in patients with heart failure. So maybe the loss of albumin in PLE from the liver lymph happens from the liver lymph leaking into the intestine. So let's do that. So that's what we did. We put a needle into the portal vein, or close to the portal vein, inject dye, and you can see on this image beautiful leakages of the lymph into the duodenum. And if you do CT, it's even better. And this is just schematical representation of the same idea. There's a lymphatic ducts going to the duodenal wall, and they are leaking. And the reason it's duodenal wall, specifically in this side of the duodenal wall, because the upper abdomen is a concentration of lymphatic cells coming from all over the place, and eventually end up being thoracic duct. So it's like a beginning of the crown of the tree. And so there's many lymphatic ducts, many connections. So recently we explored different techniques how to treat this condition, but recently we started to use this endoscopic glue injection. what do? We do liver lymphangiography, inject blue color, see where it's leaking, and glue it through endoscope. That's how it looks like schematically. See, we inject blue dye, it goes leaking, and then we glue it with endoscope. So again, this is liver lymphangiography, of course, we do first, and then that's how it looks in the patient. So this blue dye on the right is actually leaks from one tiny hole. On the left is a little more diffuse, but it's still leaking quite in one place, pretty much. And then we stick these lymphatics directly with a needle and glue them through the needle. That's how it looks. Needles come up right now, and endoscope is plugged inside the leak. Here it comes. And we inject contrast out of fluoroscopic guidance. So this is a little bit outdated slide. We did already, it was not a year ago, we did 2 years ago. So we have 2-year follow-up, but patients did quite well. Pretty much everybody responded immediately. Of course, the problem is that we have now is recurrence. The recurrence probably 40%. Number one, is it that big deal, recurrence? Of course it is, but from the other hand, procedure is so simple. There's practically no recovery time. Patients wake up and go home. We keep them overnight, but they can theoretically go the same day. And so you can repeat this procedure, number one. Relatively easy, because the other option here is to perform heart and liver transplant, right? So if I need to go every year and get a little bit injected, it's probably a better option than heart and lung transplant. Number one. Number two, our technique is getting better. Our endoscopists are doing this better and better every time. So right, the first cases we did 3-4 hours, was so difficult. Right now with a half an hour, we can actually finish the whole procedure. So I believe our the longevity of procedure will be much more. And of course, it lack of practically no complication. No complication, occasionally we see bleeding, but it's self-eliminating. So this is another protein losing enteropathy where we found these lymphatic masses in the duodenal wall. It's not cardiac protein losing enteropathy, just sporadic. And you can see that when we inject these masses, they actually leak in the duodenum. And on the right, we inject glue. Glue is very kind of, you can see that very well. And this patient is cured. So there's a lot of new technology coming. We're working so hard to create new tools, planning tools, physiology evaluation tools. Not us, but everybody else, because it's getting people get excited. Because the moment you started to treat real patient and see the result, the enthusiasm of the research community or physician researchers goes up, and everybody will try to do something new. And we see that all the time, and it's so exciting. So we definitely, because we use small catheter wires in imaging, we can actually access lymphatic system quite well and treat it and understand what's the problem. Of course, we have to continue to develop new techniques, new processes, and so on. So, and we have to discover anatomy. There's a huge NIH effort to going on. We're part of that to discover anatomical variants of lymphatic system and understand better pathophysiology. We don't know that well. And the reason we don't know it well, because people kind of didn't care about that. Why didn't you care? Because you can understand whatever you want, but if you don't have a tools to treat the patient, so what's the point, right? So enthusiasm was not there. But right now, this is a good time for the enthusiasm. So I think it's the last slide. It was a bit shorter than I thought, 35 minutes, but anyhow, thank you for your attention, and I will start taking questions. I have 10 minutes to answer the questions. Question from Kelly Bell. if issues are created by obstructed thoracic duct require angioplasty, why aren't issues created by thoracic duct embolization? Wow, that's a question I've been asked 1,000 times. I don't know. I embolize thousands of thoracic ducts, and we actually follow this patient. And we actually published one paper that describes our outcome, and the second patient coming, and we don't have problems. So that's one of the mysteries of lymphatic system. If you occlude vessel, tissue, artery, for example, the tissue behind or distal to the occlusion will die. And lymphatic system is different. You can occlude lymphatic part of the lymphatic system and collaterals develop and decompress it, but some people cannot tolerate it, and we don't know yet who are these people. So again, I continue to do embolization, and it works well. There's no complication, but definitely we do angioplasty and surgery more. Elena Galanza. It is well known that thoracic duct lymph delivers disease cell and biomarkers directly to systemic blood circulation, but we have no clinical method today to test thoracic duct lymph. Do you think that's important for disease diagnosis and therapy? Do you have any hypotheses, ideas how we can do it in future? Yeah, we actually do that. Every time we go inside thoracic duct, we sample thoracic duct fluid before embolization or angioplasty and send to our immunology, and we learn a lot from that. Number one. Number two, we have an ongoing study in collaboration from New Zealand surgery department. Dr. John Windsor, he's the head, where we're trying to divert the lymph, toxic lymph in patient with septic patient. It's just the beginning, we don't know, but the data is very, very strong that if we divert this lymph that comes from infected gut outside the body, we can prevent systemic response. But generally, it's not easy to get into the thoracic duct. Of course, I do it for living, but it's not that many. I mean, a lot of people do it, but again, people still, there's not indication. We don't understand what we are going to learn about that when we sample thoracic duct fluid. But definitely, a lot of people think about that. So maybe in the future, the moment we know that there's a certain problems, I'm sure we'll figure out relatively easy ways to access a thoracic duct. Questions from Brad Carroll. What do you foresee to be potential option for in future development for patients with CHF, a shunt between thoracic duct and immune system? Maybe we don't know. It's too early to say. Definitely, we published big paper in a Journal of American College of Cardiology, where we said that problem a lot of time with heart failure is problem with the lymphatic system. It could be obstruction, it could be malfunction, it may be just too much lymph generated in the tissues. So we're doing studies right now very, very aggressively, and other people in the world. So hopefully we'll have answers within the next 2-3 years, and maybe it's shunt or something else, or maybe other approaches. I cannot tell you, it's too early, but I'm sure there will be some type of lymphatic treatment for heart failure. There's already out there one company that does that, not very successful at this moment, but they're working hard and they are funded, so hopefully they will get it. Can you discuss in more detail scrotal lymphorrhea and glue embolization in conjunction with LVA surgery? We do primarily glue embolization. We did only once in conjunction. If patient has a just scrotal lymphorrhea with minimal edema, embolization will work amazingly well. With edema, it's a bit more challenging. So unfortunately, every case is very, very unique, and we have to figure out. What I can tell you that scrotal or vaginal lymphorrhea can be treated very, very effectively. We're actually publishing paper right now with 15 patients. But this combination of scrotal lymphorrhea, scrotal edema or leg edema, a little bit more complex, and every patient, we're still working on that, and every patient has to be a little bit, it's very, very unique case. So we need to tailor the treatment to every patient. Justine Shenik, is this type of imaging been used to study or treat lymphedema? No. The imaging for lymphedema is MR lymphangiogram geography, but different one. Also, we inject contrast inside the tissue, but not into lymph nodes, but inside the tissue. So we kind of do that a little bit, but our focus is more on central lymphatic system. Are these techniques revealing that some so-called cardiac failure may be lymphological etiologies, chronic lymphatic failure insufficiency? That's what we think, but we didn't prove it yet. I noticed that there are no cases presented of only lymphatic issue malformation interventional of extremities. Why? From an imaging perspective, if patient presenting with Milroy, have you found other problematic issue with other lymphatic channels, blockages, malformation of thoracic duct? We stay away. First, I only have a limited amount of time. You are absolutely right. We have, of course, we see some patient presented with lymphedema and protein-losing entropy and chylothorax. And there's a separate big topic that we're not very, we didn't develop that yet. We're just understanding, collecting the data, trying to understand everything. But by all means, there's a association, and we see quite a few patients with lymphedema, congenital lymphedema, and other problems such as ascites, chylothorax, and protein-losing enteropathy. We're still working on that, and we'll be happy to provide diagnosis and participate in our research efforts. But I cannot give an answers or treatment answers at this moment for that I can present and tell this is a solution for this patient. Again, it's very, very variable, and every patient gets its own solution. If we are even successful, because this is more difficult cases. Generic chylothorax PLE, extraordinarily complex and different. And we just started to understand those. And we just started to differentiate different types. And the ones that we clearly can treat, and ones we kind of think that we will treat in the future. Will any of these procedures help with secondary lymphedema, developing my right leg after having right leaf? No. This is not our focus, unfortunately, and this procedure is not, because I don't not deal with lymphedema. There's a lot of people who deal with lymphedema. We're focusing on central lymphatic system. Gina Baumgarten, are you able to use imaging on children to diagnose the cause of primary lymphedema? Again, we start trying to stay away with lymphedema. From lymphedema, if patient has chylothorax or PLE and lymphedema, they come into us. But our focus during this treatment will be primarily chylothorax and PLE. Do we work with surgeons that do lymphedema surgery? Absolutely, but it's still in our center. We focus primarily on central. It's within 1 or 2 years. I'm sure we'll start do more and more lymphedema treatment, but again, it's not me, it's a surgeon I work with. All right. Georgia Tsipakis, I want to say thank you. Okay, I heard you mention lots of young women get a lot of pain below. Do you mean in surgery or prior? In general, I suffer a lot, have a long time, but no one seems to understand why I have lymphedema and lipedema and so on. So it's a new thing. So obstruction of the thoracic duct, narrowing thoracic duct, can cause abdominal pain. We only did a few patients. We published a paper about that. I'm sure we'll see a lot of patients, and slowly we start to understand who are the right patient population. Because when the thoracic duct obstructed, we know it's a real thing for sure. We know that the patient with obstruction of thoracic duct, some of them have pain, and after we open it up, next day pain disappears. But from total obstruction, we move into the narrowing and to clotting. So, so if it's not obstructed, we open, it works. When we reach the area of narrowing, we're not sure yet. So the more patient will do, the better we know. What are the success rates of patient with lower primary lymphedema versus secondary lymphedema? Again, I don't deal with lymphedema. In other questions, do you have any publication with New Zealand collaborators? I asked about thoracic duct sample because we recently found that a very early primary tumor is able to disseminate aggressively circulated tumor cells through thoracic duct. So analysis of lymph samples seems to be important. There's a bunch of papers from the old literature, not New Zealand, about tumors in thoracic duct and infection. Again, we're not there yet because this technique is a little bit invasive right now to get sample of thoracic duct fluid. And we need a little bit, and specifically in New Zealand, focused on the tumor. They focus on toxic lymph in ICU patients. So you wouldn't find papers related to that, but the New Zealand group is very, very, very active, publishing multiple reviews and studies. So John Windsor, and I most of the time I'm part of their papers right now, but John Windsor, he's always there, and Anthony Phillips, Anthony Phillips and John Windsor, they are two main people. It's University of the capital of New Zealand. I completely blank on the name of the university. So there's multiple papers about specifically sampling, but not for tumors. I think this is the last question. Thank you very much for your attention. It was always a pleasure to present, to learn, to try to share whatever we learn and knowledge. Steve, anything else I'm missing, Felix?
That's it. Thanks so much for your time and for a great presentation today.
Thank you very much. And of course, I open for more questions. If you can send it to Steve or Phyllis or Colleen, and they will forward it to me, I'll be happy to answer. Thank you very much.